I'm Dr. Lloyd Sederer with Columbia Psychiatry Media and Medscape, and my guest today is Dr. John Mann, Professor of Translational Neuroscience at Columbia Physicians and Surgeons, and we're going to focus on ketamine. Welcome, John.
Thank you.
Expert in mood disorders, and let me say a word about depression, because near to 20 million people in this country alone suffer from clinical depression every year. And what that means is that they have a functional impairment in addition to their suffering and are at risk to take their own lives. This is a very prevalent, very painful and disabling condition. And the treatments that we've had, particularly psychopharmacological treatments, have been more or less the same for the past 20 or 30 years. And we've asked Dr. Mann to come here today and talk to us about a novel psychopharmacological treatment, now in two preparations, ketamine and its nasal preparation, esketamine. So John, welcome. Tell us a little bit about this medication, this agent. Teach us about ketamine and esketamine.
So ketamine and esketamine, which is a component of ketamine itself, is different from traditional antidepressant medications in three fundamental ways. The first is that it acts very quickly. Traditional antidepressants take 4, 6, 8 weeks to work. And this means that the patient has to put up with a great deal of suffering waiting for the medication to work, and the probability of the medication working isn't fantastically high. Maybe 50 to 70% of individuals will respond eventually at the end of this rather long time period. But ketamine, when it works in hours. So that is a totally different time scale. In fact, the other aspect of ketamine, the second aspect, is that when it does work, it often works very robustly. Even though it's a quick acting antidepressant, it also works robustly. So the patient often feels distinctly better. And very often when you're using traditional antidepressants, it takes a while for the improvement to reach the point that the patient is confident that they feel clearly better. Sometimes they
all the time, as a doctor treating that patient, you're trying to keep that patient's hope alive, even though they don't have such substantial evidence that they're going to respond.
Exactly. One of the difficulties of keeping patients on track with traditional antidepressants is that they get all the side effects immediately. After the first dose or two, they have all the side effects, and yet no benefit has emerged. So in many ways, patients sometimes feel that they're going backwards. They now have all of their depression plus the side effects of the medication, and then the benefit isn't there. And sometimes the benefit is subtle at the beginning, and their families even will notice it before they do, which is not of great comfort to the patient. So they need a lot of support and help to stick with it. But with ketamine, it's rather different. You come in, you have the treatment, and the patient in a couple of hours feels noticeably improved. And not just a bit improved, but they feel, many of them will feel distinctly improved. So that's a second feature which is important and extremely helpful in treating patients. The third thing that is very important for patients and for clinicians to appreciate is that ketamine will work in patients that have a so-called classically described as a treatment-resistant depression, meaning they've tried several other types of antidepressant medications and they haven't worked.
Is that a prerequisite for treatment with ketamine, that there have to be a number of treatment failures? So
in the labeling for the esketamine, the intranasal ketamine, it is considered that you should try the other antidepressants first and then use this when they don't work. But off-label, more and more clinicians for certain types of patients will just begin treatment with ketamine because the patients describe previously with other doctors and in other depressions that they've tried all these different medications and they haven't been terribly effective. And the patient is very distressed. So the fact that the ketamine can work even when the other medications have failed is a huge advantage. There is another feature of ketamine, a fourth feature, which is important. It also has a pronounced benefit for suicidal ideation.
Yes, your research has reported on that as well.
Yes, we
Please
published.
tell us about that, because what I've learned over the years is that these are in some ways comorbid conditions, the depression and the suicidality, and they both have to be addressed in order to keep somebody alive so that they can respond to treatment.
Yes, that's a very important point. If the patient's suffering from depression and the antidepressant takes weeks to work, the patient may lose hope during that time and be overwhelmed by the suicidal ideation, be no longer able to control it or resist it and the impulse to kill themselves. So a lot of the management is to try and help support them so that these thoughts never become too compelling. And often for those kinds of patients, we have to consider hospitalization to protect the patient so that they can stay alive long enough in order for the antidepressant to work. But ketamine not only has this very rapid effect for their depression, it has a partly independent effect on suicidal ideation, equally rapid
And robust.
and robust. So it kind of renders the patient safer while we're waiting for them to get better in terms of their depression. It also helps their depression a great deal. All of these sound almost too good to be true. So there are some limitations that we have to keep in mind. One limitation is that a single administration of ketamine will produce this robust improvement, but it will only persist for most people for 5 to 7 days.
Is the same true duration for esketamine as well?
Yes, it is. And then the patient will gradually begin to deteriorate if you do nothing. But as we showed in our study, a randomized clinical controlled study with ketamine for suicidal depressed patients, if you revamp their medication as a consultant psychopharmacologist would do, optimizing it in the light of what they've had in the past, you can sustain the benefit so that they're pretty much as good at 6 weeks after they've had their single dose of ketamine as they were 24 hours after the ketamine.
So the implication here is that a person can receive both ketamine and some of the conventional antidepressants at the same time.
Exactly. In this study that we did, half the patients or more were actually continuing on their previous medications, and we just gave them the ketamine on top of that. And then we examined their treatment and made it a little better. But it worked very well. In practice, people use two approaches. One, and this is the approach used by most ketamine clinics, they will give ketamine a bit like ECT. They will give 6 doses at a frequency of about 2 per week. And then they will reduce the frequency of the dosing down to 1 a week for a few more doses, and then 1 a month.
And this is a ketamine infusion.
And this is generally, yes, has been a ketamine infusion. This approach seems to work quite well, but it may not be necessary. Another strategy is to give 1 to 3 doses of ketamine, and if the patient doesn't respond robustly to 2 or 3 doses, they're not going to respond to subsequent doses.
So that's a predictor. That initial response is a predictor of a future response.
Exactly. Now, so if they haven't done well with the 2 or 3, then you know you've got to use other treatments that we can talk about. But if they do well with the 2 or 3, then you've got a choice. You can either complete the treatment course with ketamine and then give them antidepressant medications, or just manage them with ketamine alone. Or you can do what we tend to do, which is after a small number of treatments, we only manage them with medication, and we use ketamine as a kind of rescue medication if they need it in the future, and that is only true for a minority of patients.
One of the things that we've learned about antidepressants is that for some people, they have a very good beneficial effect, and then they wear out, and then a person starts to relapse. Is there enough enough time for ketamine to be studied in that regard as a intervention for people who are no longer responding to the antidepressant that they're on?
So we do not really know the answer to that question. My own experience, anecdotally, treating very seriously ill patients, is that sometimes the ketamine will work very well the first time or the second time, and then if in the future you try to use it as a rescue medication, it might not work as well. So there is some clinical experience that suggests that that may be true for some people, but we have no idea about the frequency with which this happens, or the time course with which this might happen. That's all uncertain. Moreover, most of our controlled clinical trial data comes from either one dose of ketamine or a few trials where people have gotten multiple doses with a bit of a taper. But there are very few of those types of studies.
So we're still learning about the use of this medication. Let's just touch on, because you reference importantly the side effects of antidepressants. What are the side effects and what are the risks of administering ketamine?
So we know a lot more about the immediate short-term side effects of a single dose or a few doses of ketamine. Most people will get a kind of tripping experience. So they'll feel a bit unreal, or their circumstances feel a bit distorted, and they may develop some strange ideas. These symptoms, most patients don't enjoy those symptoms, even though I know ketamine is used as a party drug and so on and so forth, but it seems that the context matters.
Yes.
And in a clinic context, most patients don't enjoy those symptoms, but they put up with them. They're not terribly severe in general.
And they're part of the preparation of the patient that this may happen.
Exactly. We try to explain the potential for these symptoms, and most people get them. And they almost invariably terminate with the cessation of the administration of the treatment. So it's short
How
duration.
long is the infusion
take? Usually, traditional infusion is 40 minutes, and it's always in a clinic setting. And the S-ketamine intranasally will also have to be given in a clinic setting,
because of the concern that a patient may have these
tripping effects. Exactly,
tripping
dissociative, derealization effects, and be a bit disturbed by that, and we need to monitor that. So, and they're probably going to be in the clinic about the same period of time, because it takes about the same period of time for these effects to wear off.
Is there a difference in the effectiveness between ketamine and S-ketamine, the intranasal?
There is, and I'm going to explain that in a moment. But the other thing that some people get is a little nausea. It's, in our experience with the intravenous ketamine, it's rarely problematic, very rarely problematic, mild. And their blood pressure will be raised slightly. So it's good to know that the person's blood pressure is controlled before they begin the treatments, and it's, I think, important to monitor it during the treatments. S-ketamine is a bit different. The intravenous administration of ketamine, and we've now just completed a very important clinical trial funded by the NIMH here at Columbia, is that S-ketamine, or ketamine itself, the dose and the blood levels are very closely related to the robustness of the clinical response. And when you give a drug intravenously, you give a very reliable dose of the drug. And when you give the drug over 40 minutes, you're spreading the dose administration over a period of time so that it doesn't peak very high. The side effects are going to be proportional to the peak dose. When you give it intranasally, you give the drug over a much shorter period of time. Even if you use more than one intranasal administration to give the whole dose, it's still a relatively shorter time compared to the 40 minutes, which means that to get the equivalent dose intranasally, you're going to have a higher peak.
Yes.
And therefore, the patients who are getting it intranasally, one can predict that they're going to have more side effects.
Right. And they're cautioned about, they're informed about that as well.
Yes, that should be explained to the patient. Yes, you will not need an intravenous line inserted, which is, some people might find highly appealing and advantageous. But you will probably have more side effects. And also, in general, intranasal absorption of drugs is more erratic.
Yeah.
So the predictability of the blood level and therefore the degree of antidepressant effect is not as good intranasally as intravenously. Now, all of this is kind of clinical experience, anecdotal and theoretical pharmacology, because nobody has actually done a head-to-head controlled comparison.
What about the cost of these both of these preparations? Are these covered by insurance at this point, or do they still want for that type of FDA approval, commercial insurance payment? What does an individual or family face in terms of cost for this treatment?
There is a bit of a range in pricing between ketamine clinics around the country. So it's always important to find out what they charge per administration. And then it makes a difference whether you have 2 or 3 administrations versus 6 plus further tapered administrations. So clearly the cost can vary a great deal. But it's generally not covered by insurance. So most people are paying out of pocket.
Yes.
The intranasal ketamine is still in a matter of negotiation at the moment, but they will resolve this before it's full on marketed. So it's not clear at the moment the relative cost of the 2 routes of administration.
Just going back, because we've focused its use for major depression, does it have utility in bipolar depression? Does it have utility with dysthymic states? What's the range of effectiveness?
So we have done initial studies, and some other people have, in bipolar depression. And in our view, it's probably going to be as effective in bipolar disorder, depression, as it is in major depressive disorder, unipolar depression. We haven't seen any manic episodes triggered, but we don't give repeated doses.
Wow.
So, it does seem to, and we do allow them to stay on anticonvulsants or lithium.
Mood stabilizers.
Mood stabilizers. Yes, so that's obviously helpful. And generally the people with bipolar disorder who come for ketamine treatment for their depression are coming on a mood stabilizer because that and perhaps other conventional antidepressants have not proven to be effective.
Right, right.
So I think that seems a very promising alternative. Dysthymia is much milder, but the clinical trials are focused on major depressive episodes.
Those people with dysthymia where it seems to never go away, and I know you and I have met people like that, and they suffer a great deal, and in some ways the cumulative effect of the dysthymia is very disheartening and demoralizing and painful. That was why I was wondering if it if its application might extend in that area.
And it might, because the context that you're describing is really what we also call double depression.
Yes.
So the people, maybe a fifth of people with depression, it's really chronic. They're never really euthymic. They never really feel normal or good. They're always a bit depressed, but they've learned to just kind of put up with that. And then every now and then they have these periods when they get really deeply depressed.
Yes.
So we have seen that when you treat these people successfully with standard oral antidepressants, that sometimes when you ask them, you're feeling better, they seem a bit puzzled by the question, because actually they feel better than normal, because their dysthymia has also responded.
Yes.
So that's always a gratifying situation for patient and doctor. But we don't have enough experience with ketamine yet with that subgroup of patients to feel, to have a sense of how often that might happen with ketamine.
I want to swing back to the anti-suicidal properties that you had mentioned as a fourth feature. I heard from a colleague at a state hospital in another state of a patient that they had admitted in her 20s who did not have major depression, but was persistently suicidal, constantly trying to hurt herself in any way she could. And but seemed to be more a product of personality disorder, borderline personality, impulsive problems. And in the end, they gave her an intranasal esketamine. And the response was just as you described. It was robust, and her self-injurious behavior dropped in a very pronounced way within a day or two, but then did require administrations a couple times a week in order to keep that suicidality at bay. And so I guess I'm using that as an example to wonder, is there an application here for people who are suicidal who may not have features of major depression or bipolar depression?
That's a very interesting suggestion for which we have no data-based answer. However, we have a clue from the study that we did that was published in the American Journal of Psychiatry. Because when we did further analyses in that study, and we've published a couple of sequelae papers based on that study that talk about some of this, the reason that people die by suicide, make suicide attempts, is not entirely due to the fact that they suffer from a mood disorder.
Yes.
Because only a minority of individuals with a mood disorder ever make suicide attempts. There's a subgroup that are at risk. So here at Columbia, we've promulgated a kind of stress diathesis model for suicidal behavior, where the stressor could be life events, but that's external, but the internal stressor would be like an acute episode of depression. But there's also the diathesis, which plays an important role, which is the predisposition.
Which is, sorry, I was going to ask you to
yes,
you
the predisposition. Now that has several elements to it. One is altered decision making, so it's a propensity to go for the short-term quick reward. In other words, for a patient, immediate relief rather than the delayed gratification of waiting for the antidepressant to work. So they're more prone to act on the pain of the depression and terminate their lives to try and end that pain, rather than wait and hope that in time there's a chance the antidepressant will do it instead. But they have other things too. They're interestingly enough, their problem solving and memory functions and learning functions are not as good.
Yes.
So when confronted with a problem, they can't stick to it for as long. They're not as good at solving it. They're more likely to collapse and give up. And these kinds of cognitive deficits are very important. And interestingly enough, ketamine improves these other brain functions. So they make the patient more resilient. So it not only suppresses the suicidal ideation, but it reduces the chances of acting on these thoughts. And so the anti-suicidal effect of ketamine is more than its antidepressant effect.
Suicide is the only preventable cause of death in this country where the rates continue to rise. So this is really an important part of understanding the potential promise of this medication. I want to finish by asking you two further questions. The first is, what haven't we covered? What else might you want to say about this medication and its use to our viewers? That's the first question.
So my goal in treating patients is to try and use the least amount of medication possible.
Mm-hmm.
And with ketamine, we do not really yet know the long-term safety of this treatment.
Mm-hmm.
People who, it's been used for many decades in anesthesia, but people don't get repeated anesthetic doses of ketamine. And higher doses of ketamine given repeatedly have been shown in preclinical studies to produce little lesions in the brain, which is not good. But now we're using much lower doses, but we are potentially moving into an area where we could be giving multiple doses of ketamine to patients. We should remember that we need to be cautious about that, and if we don't need to give them more doses, we shouldn't. We should know that there is a potential downside that we don't fully understand yet about giving ketamine repeatedly. And that's aside from its potential abuse potential, which we
Say a word about that.
So
please.
We know that people have employed ketamine for physical pain and emotional pain, and when they administer it themselves, they tend to get dependent on it. And in a clinic setting where it's given in a very formal and structured fashion, a bit like the administration of opioids, it's much safer, and the risk of abuse and diversion is minimized. But we need to remember this drug does have the abuse potential and perhaps other yet not fully measurable neurotoxic effects.
Thank you. That's very clear. Last question for our viewers. If physicians and other professional clinicians, nurses, want to learn more about this medication, where do you suggest they turn? What are the websites? What are the agencies that you think have accurate, reliable information for people to learn more about ketamine?
So I think that there are several possibilities. The NIMH often offers important information for patients and their families. And that's a unbiased, very scientific, thoughtful source of information, and better than just trolling the internet for information. People are much more sophisticated now than they were 20 years ago in these matters, and scientific papers are much more accessible to the public, and reading papers in recognized journals and so on is also a useful way to gain information. And for example, one of the major papers that we published on ketamine is in the American Journal of Psychiatry, which is available to anybody on the internet to read. And if not, you can ask for a copy, and it can be obtained. So I encourage people to make their own inquiries and talk to more than one doctor. And
An informed patient and family is the best partner a doctor can ever have.
Yes, we encourage that in all of our patients.
Yes. Well, I want to thank you very much, Dr. Mann, for your work in this area, for joining us, Columbia Psychiatry and Medscape, and teaching us so much about what is truly a novel psychopharmacological agent where we still have a lot more to learn.
Thank you.
Thank you.
It's a pleasure.